The broadcast is now starting. All attendees are in listen-only mode.
It's a couple minutes after 8 o'clock on Eastern Time on my watch, and this is Tim Kosinski, Dr. Tim Kosinski from Bingham Farms, Michigan. And we have a nice, large attending audience with our webinar tonight, and hopefully you'll appreciate the information that we're going to be able to share. Our topic today is predictable extraction and grafting techniques to ensure implant success. And who am I? Who's this Dr. Kosinski guy? Well, I'm a general dentist in the Detroit area. The practice is in the suburbs of Detroit. And if I really believe, my father always told me, if you provide a great service at a fair price, you'll always be busy. And here we are in Detroit, probably one of the hardest hit economies in the country, way before the recession hit in 2008. But we've been fairly successful. I do a lot of, as I said, I am a general dentist, but we do a lot of extractions, grafting, and I place a lot of implants. I do document most of my cases, either with photography or with video demonstrations that are easy to see on drkosinski.com. And I'm going to try to show you some of the newer cases, try to keep this webinar up to date and fresh for you. I've published over 160 articles and have placed well over 11,000 implants myself as a general practitioner. And last year alone, we placed over 1,000 implants in the practice. So what I want to demonstrate is how I can help you and others in my profession develop the skills that I have as far as providing some real quality techniques to your patients. Dental implants are the hottest thing going in dentistry today, and hopefully all of you are getting properly educated. But as a precursor to dental implant procedures, it's imperative that we learn proper atraumatic extraction techniques, and we learn how to graft socket sites predictably. I'm going to show you some of the materials that I use. I know there's a lot of products out there that you can get information on, but I'm going to try to focus in the next hour on products that have worked well for me, and you're going to hear me use the word predictable a lot. I'll show you materials and techniques that will make you very successful in your extraction and grafting techniques in preparation for dental implants. This is not really a dental implant training webinar. We can do that in the future, but more or less creating a site, a foundation, so to speak, for your dental implants in the future. I'm going to show you the products that I used over my 30 years plus of dental experience. And I also evaluate products for several companies. And so I get to try to use a lot of products clinically. And again, let's whittle this down to the products that I feel are most appropriate for you to get become very, very predictable in your clinical techniques. The clinical result is the key, and if we can provide you some techniques that allow you to ensure that your cases will work, we can grow bone today. We can predictably grow bone today, but you must follow a specific protocol to be able to achieve that end result. You know, I'm not paid by any company to do this. I'm going to show you what I use in my practice every day and what works for me, and hopefully you'll appreciate it. We do have Golden Dental Solutions supporting this program tonight, and Kurt Lawler from Golden Dental Solutions at the end of the program will provide you some valuable information about their products and you know, how to make you more profitable and confident and competent in your abilities. So our objectives today are going to be simple. We're going to demonstrate some clinical tips to ensure that you achieve proper foundation for dental implant placement in the future. Atraumatic extraction techniques is very important to me, and when I talk about atraumatic extraction techniques, I'm talking about several things. I'm talking obviously atraumatic to the bone. To me, bone is gold. When I'm placing dental implants, the more bone I have, the better. But also atraumatic to the patient. I want your patients to have a positive experience with their extractions, and I can't tell you how many times that we've demonstrated these techniques with the golden physics forceps, where my patients have looked me in the eye and say, "Oh my gosh, you're kidding! You're done. This is an amazing event for me." And that's your best advertising. Patients that are happy and pleased with your service are going to tell their family and friends how satisfied they are. And finally, atraumatic to the doctor. I'm a big believer in saving your body. Save your arms, your eyes, your back, and these techniques certainly allow you to save some of the muscles in your body. We're going to talk about site preservation with grafting materials and why it's important. We'll talk about immediate implant placement. We'll talk about grafting and membranes and the different types of membranes that we use. And we'll talk again a little bit about the different types of materials, and you can decide from that point what you feel is most appropriate for your practice. A membrane is simply a barrier. I like to call it a Band-Aid to our patients that prevent invagination of epithelial tissue into our grafted site. And the membrane is a very, very critical part of the procedure that I'm going to show you today. And if you're able to stay tuned and watch the entire program or watch it again on a future replay, I think some of the techniques we're going to show you are going to, again, make the results very predictable. And everything that I do is going to be step by step. Again, I do a lot of photography and video, and you'll be able to, with a little bit of help, immediately implement socket grafting techniques into your practice. So we want to consistently get these type of results in our practice. We have a maxillary molar tooth that we atraumatically remove, atraumatic to the bone, atraumatic to the patient, atraumatic to the doctor. We'll show you some grafting techniques and some membrane placement techniques which allow us to eventually properly place implants in an ideal position where the tissue is healthy and firm, and allow us to restore our patients with implant retained crowns. We're able to really provide a wonderful service for your patients, and it's a wise business decision on your part. So let's start. Step one, let's talk about atraumatic extractions. These are the type of patients that I see in my practice. I'm in the suburbs of Detroit, in a nice area, but these are patients that do come to my practice wanting help. And you might say, well, oh my gosh, how can that be? You know, how can people walk around with this? Well, there's a number of reasons why patients choose to function like this. Number one, they could have had a bad experience in the dentist in the past, a bad extraction experience where they were afraid to come. It could be a budget issue. Oftentimes, cost becomes a real limiting factor for our patients. But oftentimes, these are adults that have raised their families, their family, their spouses and their children come first, and at a certain part of their life they realize that it's time for them to do something for themselves. And these are the patients that routinely present to my practice, where we're able to remove teeth atraumatically, give them a good experience, graft sites, and eventually place implants. And some of the work that we do is pretty remarkable and pretty exciting. We do a lot of full mouth reconstruction, a lot of hybrid reconstruction with dental implants. Dental implants are a great foundation for not only a single tooth, but multiple teeth, bridges, and overdentures. So what does this mean? Everything that we do starts with proper extractions. All of you that are listening today have seen situations where bone is minimal. If you're not placing implants, there's two reasons probably why you're not placing implants. Number one, you're afraid of the mandibular nerve. You're afraid of the mental nerve. You're afraid of hurting the patient. And number two, you're afraid of the maxillary sinus. Well, a lot of these issues with minimal bone can be resolved by properly extracting teeth and grafting, trying to maintain that bone for future implant sites. And if you're referring your extractions out, I think it's imperative that you become educated and learn techniques that can make this a viable option in your practice. It's a very rewarding part of dentistry, but for those of us who just don't like extracting teeth because we find them difficult, hopefully we'll show you some techniques that will take some of that fear and apprehension about your procedures. Others of you may extract teeth, but it may take you a long time to do it. or it may create a lot of stress in your professional life. And hopefully we're going to be able to eliminate or minimize a lot of that. There's a huge potential for you, and the rewards all start right here. Our conventional techniques when we're removing teeth, you may have a patient that needs a tooth removed, and you tell your staff or your team member, we're going to remove a molar tooth, go get me the instruments. And inadvertently they will, or normally they will bring you a big tray of different instruments to try to remove that tooth. And I often ask, why do you have so many instruments? Well, we have so many instruments because removing a tooth can be very, very difficult and very trying. And we have different tools that will allow us to remove certain types of teeth, certain shapes of teeth, root tips. And one of the most traumatic things that happens to us in practice is breaking a root tip, where we spend an inordinate amount of time trying to remove a root tip, from a socket site. It can be very, very traumatic to us. And remember, we're trying to create atraumatic situations. So normally, I would assume most of you who are not versed in the use of the golden physics forcep, you would probably take some type of instrument, a periosteal elevator or periotome, and go around the tooth and kind of cut the periodontal ligament. Then you would probably take some kind of elevator or luxator and try to move the tooth a little bit. And then I assume you would take some type of forcep where you would squeeze that tooth and do some kind of motion, either figure 8 or buccolingual or facial lingual or right and left or mesial distal. And you're trying every which way to loosen that tooth and get that tooth out of the socket. Well, let me show you some techniques using the golden physics forcep, which I think will change the way you practice. Our patient here presented with a maxillary right molar tooth, central incisor tooth that had failed. We had an endodontist evaluate it, and we had a fracture in this tooth, and the tooth needed to be removed. Now, this is a very traumatic experience for our patients. Losing a front tooth, if you can imagine, losing a front tooth can be very, very traumatic to any of us. And so maintaining as much bone as possible in that area is critical to the long-term aesthetic result. I'm a big believer that our implant dentistry is prosthetically driven. So I'm trying to visualize the final restorative result prior to any surgical intervention. So we have a tooth that we're going to have to remove. What do we want to remain? What's important in this situation? Well, maintaining the facial plate of bone would be very, very nice. We like that nice stippled attached gingiva on the facial aspect. And so maintaining that facial plate of bone is important. But as important is maintaining that interdental papilla. And how do we do that? Well, interdental papilla is supported by the interseptal bone. So maintaining that interseptal bone is very important to me. So we don't want to damage or cut away that interseptal bone. If we lose bone, the tissue hollow, which can create a real big aesthetic problem in the future. So here's the palatal view of this tooth that needs to be removed. We're going to use the golden physics forcep, which is a very unique instrument that has two components to it. The first component is referred to as a beak, and that's kind of the flattened shovel-shaped edge that will engage the palatal or lingual aspect of a tooth 1 to 3 millimeters subgingival. This is the working end of the instrument. This is the part of the instrument that is going to create tension onto that palatal root surface, which is going to create a physiologic reaction of the body. The body's going to release an enzyme which will break down the periodontal ligament. Well, what's holding this tooth in place? The periodontal ligament. And if we're able to disintegrate the periodontal ligament without cutting it, without damaging it, the periodontal ligament will melt away, which will allow us to remove this tooth atraumatically up and out of the socket, following the very unique arch form of that instrument. The second part of the instrument we refer to as a bumper. And this bumper has a green silicone cover that is disposable that will act as a fulcrum on the facial aspect of the extraction site. It is a fulcrum only. It is not a working end of the instrument. It is only allowing us to rotate the beak onto the palatal aspect of this root up and out following that arc. We are not squeezing this instrument. You're going to hear me say this several times. Rather, we're creating tension onto that palatal aspect only. In so doing, with a little bit of rotation of my wrist towards the nose, this tooth, in a matter of a minute or so, will disengage. We call it a pop. It's not a pop you hear, rather it is a disengagement of the root structure out of the socket. And we'll continue to rotate, and that tooth will pop. The periodontal ligament is loosened. We will then take what we refer to as a tooth delivery instrument. I will simply grab onto that tooth structure and simply rotate right and left, or mesial distal, and that tooth out of the socket, maintaining that facial plate of bone and maintaining that interseptal bone. At this juncture, you can decide to graft this site or immediately place an implant, and we can talk about another case like that in the future. But you can see there's no trauma to the facial aspect of the extraction site. The bumper is only acting as a fulcrum. We are never squeezing the instrument, rather just simply creating tension onto the palatal aspect, which allows this tooth to be easily removed out of the socket. We had a vertical fracture in this tooth, and we get a nice extraction site that can be easily repaired. The most predictable results in my hands are from the physics forcep, and I can honestly tell you that I would not practice without these instruments. There are 4 instruments: a maxillary right, maxillary anterior, maxillary left, and a universal lower. I use it just about every day. If I'm going to remove a maxillary front tooth, I will simply have 1 instrument. I don't use a periotome normally. I don't use a periosteo elevator. I don't use a luxator. I go right to the instrument, which allows me to remove the teeth quite easily. And I'll show you some other examples. As I said, there's 4 instruments with disposable bumper guards. Kurt Lawler from Golden Dental at the end of the program will discuss the cost of these and the specials that they have. I think it's most appropriate for them to do that with you. There's also a second set of instruments that are referred to as the molar series, and it's simply 2 instruments. The technique or the protocol is exactly the same, meaning we're creating tension onto the periodontal ligament, which causes an enzymatic reaction, but the design of the instruments are a little bit different, where you may have a very shallow vestibule in the molar area, or you may have teeth that are very grossly decayed on the palatal or lingual aspect, and you can actually rotate this around and engage the facial aspect of a tooth and remove the tooth towards the lingual or the palatal. Pretty amazing instruments and very, very versatile set of instruments. So let's look at a single extraction and a molar. Now, this tooth was deemed non-restorable, and we were going to remove it. Mandibular molar teeth can be a challenge for us, especially root canal treated teeth. You can see that an apical was done at some time, and the endodontist deemed that this tooth was not treatable, and it needed to be extracted. Now, when the roots of the teeth are rather convergent, meaning they're not spread, we can oftentimes remove this tooth in one motion using the golden physics forcep. So here we have a tooth that needs to be removed. I'm going to remove this crown first, but using a very, very special instrument, again, available through Golden Dental Solutions. It's called a wham key. For those of you who have not seen this before, I strongly recommend that you get it. It is a time saver. So it's 3 sets of instruments that have like a little ball at the end. And normally, if you were going to remove this crown, what would you do? You would take some type of burr and you would section it from facial to lingual. Then you would take an instrument and kind of separate it and take the mesial and distal pieces off. And that's fine. That probably works well for you. It's a lot of work. It's expensive to use the burrs. But what do you do if you have a zirconia crown? Those are really hard to remove. So what we'll do is we'll use this wham key technique. And what I'm doing here is I'm simply going to take a burr and I'm going to make a little ovate opening into the facial aspect of the crown. Now, what I'd like to do is I'd like to be able to place that wham key ball on the occlusal surface of the tooth. So I'm making my little opening in the facial aspect of the crown in the occlusal third, so to speak. Normally the preparation is about a third down the tooth, so I'm kind of guesstimating where I think that preparation would be. But here I'm going to make my little opening, and I'm going to take my wham key instrument, and I'm simply going to place it into the opening up through the crown onto the preparation, the occlusal surface of the preparation, and I'm simply going to rotate my wrist, and that crown will pop off. Now in this situation, I'm going to demonstrate the extraction technique because this tooth is non-restorable, but how many of you remove crowns to replace them because of a decay or a contacts? And this is a real time saver and a cost saver with burrs, especially with zirconia. And also, your staff members that are making temporaries for you would normally make an acrylic temporary or a composite temporary, which sometimes breaks, they fall off. What better temporary would you have than the existing patient's crown? And all your staff has to do is reline it or put some composite on the facial aspect of the opening, and you have a beautiful temporary. But in this situation, we're going to section this root. And as I said, with the wham key, it's a wonderful instrument. Look at it. It works great with zirconia crowns. You can use it as a temporary. You can use it for bridges. And oftentimes you can remove crowns without significantly damaging the tooth preparation. So because we have divergent roots, as I said, mandibular molar teeth often have divergent roots. If they're convergent, then removing the tooth can be done quite easily using the physics forcep, but that isn't often the case with the mandibular molar. So what I will simply do is take a 557 surgical burr, and I will section the tooth through the furcation. Now you want to make sure that you are completely through the furcation in this instant. Then I will use the physics forcep to simply remove the mesial and distal roots separately as if they were single rooted bicuspid teeth. So here we sectioned all the way through. I'm taking my physics forcep, engaging the beak onto the lingual surface here, 1 to 3 millimeters subgingival, placing the bumper as far down the vestibule as possible, and simply rotating my wrist, not squeezing the instrument. There is no force put on both sides of the instrument. Rather, the force is only put on the lingual surface here, and as you will see, the tooth will disengage up and out of the socket, following the arc of the instrument. It's a brilliant product. I will then take my tooth delivery instrument and remove it. Then I'm simply going to the mesial root, and in a matter of seconds, I'm able to atraumatically remove this tooth using my tooth delivery instrument, and I have an ideal socket site for whatever procedure you feel is appropriate, whether it be grafting. I personally would not immediately place an implant in this site. I would rather graft it, give it 4 months to heal, and then I can place an ideal implant in this situation. You have a socket. Now what are we going to do? So let's learn some grafting techniques and preservation techniques. In my mind, when we have a socket, I will tell my patient when we're going to remove a tooth, we create a socket or a hole. And that hole is shaped like an egg. Now every one of you imagine what an egg looks like. Well, that egg basically has 4 walls. It has a lingual wall, a mesial wall, a distal wall, and a facial or buccal wall. So in that respect, all 4 walls are intact. You now have an ice cream cone, a waffle cone, or a cereal bowl. And you can pretty much place a lot different materials in that cereal bowl, ice cream cone, or waffle cone, and the body is amazing. It will heal. And we all know how a socket heals. It heals from the apex towards the crest. And the way it heals is that our bodies will create cells that will attack the grafting material. We haven't talked about types of materials, but we will in a moment. It will attack and eat away the material, the grafting material. Simultaneously, different cells will lay down new bone. So we know that the cells that eat away the bone are called osteoclasts, and the cells that lay down bone are called osteoblasts. I don't bother talking like that to my patients, but for this indication, we can easily understand that. So if we have all four walls intact, the procedures we're going to demonstrate are very, very predictable. If we lose the facial plate of bone, which is very common, we can also very easily repair or grow back that wall. If we're missing more than two walls, that's not what we're talking about today. Okay, that's a program, that's a more advanced program. So let's keep going on with our socket grafting. And the reasons for socket grafting is we want to prevent future bone loss. We said early in the program, we've all seen that horseshoe-shaped mandibular ridge or a huge sinus. Why is that? When we have a maxillary molar tooth, that tooth, those roots act like a tent pole holding up a circus tent. So what happens to a circus tent if you remove the tent pole? Well, it collapses. So the sinus collapses and becomes bigger. Also, bone will shrink up and in or down and in when we remove teeth. So socket preservation is a very important part of explaining these procedures to your patient. If you do nothing, there's a chance that the bone will shrink to the point where they may not be able to have an implant in the future without more invasive, involved procedures, such as taking bone from the chin area or from the third molar area. Maintaining bone helps support adjacent teeth. It allows us to better plan for future options, whether it be implants or not. It could be a ponic for a conventional bridge. Maintaining that bone will give us a better functional and aesthetic result. As we like to say, it's easy to preserve now instead of trying to create later. It's less expensive for the patient. And when we're working with a company like Golden Dental Solution that allows you to purchase product that we're going to talk about today at a reasonable fee, probably 30% less than most, you're able to provide this service very comfortably for your patients. Helps to avoid future surgeries. Our materials today are very safe and effective. I have no issues taking bone from a site, from a bottle. It's very well controlled by the FDA, and we get tremendous results. And remember, when you're telling your patients, regardless of what we put in the socket, it's going to be gone in 6 months or so. The body's going to eat it away and lay down new bone. Success of our grafting depends on atraumatic extractions, minimize trauma to the surrounding tissue, especially the interdental papilla, maintain bone in the interseptal area. I'm going to show you very specific guidelines on flap design that are very important. We're very gentle with our tissue, especially in the aesthetic zone, and we want to create a site that we can place our graft in that will allow osteoclast and osteoblastic activity. When done properly, you will get a predictable result that will make you feel great. It'll be financially rewarding, and it'll also provide a great foundation for future work. So let's keep moving on to some clinical cases. Let's talk about an atraumatic extraction where all the walls are intact. We have a four-wall defect, meaning all the walls are intact. Here we're going to use a pretty amazing product. It's called Osteogen. It is a calcium phosphorus product that's been used for over 30 years. It's not sintered, and phosphorus and calcium are the building blocks of bone. It's held in a tendon matrix, and it's an amazing thing because you're able to put this product into a socket where all the walls are intact without a membrane and get a remarkable result. We'll also show you some allograft, which is human bone, and then we'll talk about tricalcium phosphate. I do use the synthetic material called tricalcium phosphate, but again, it's allows us to set a foundation that allows the body to heal into natural bone. The first case here, we're going to use an Osteogen plug. So we have a tooth that's pretty badly decayed. We all agree the tooth was deemed non-restorable. We're going to remove it. Very apprehensive patient. We want to make this experience as pleasant as possible for the patient. And So we have a very badly decayed tooth. Now, when we're using the physics forcep, we just need a purchase point. That's all we really need, is to have a purchase point. And if we don't, we can create one by taking a 557 surgical burr and kind of flattening out that lingual surface of the root. Remember, we want to place our beak 1 to 3 millimeters subgingival. And here we'll demonstrate what we're talking about. We have a tooth that has there's no purchase point on the lingual, so we're taking our burr, creating a purchase point on the root of the tooth, placing our beak, placing our bumper into the vestibule, and simply rotating our wrist, allowing the instrument to remove the tooth up and out of the socket very, very predictably. Not damaging the facial plate of bone, maintaining all 4 walls in this situation. So a very, very nice atraumatic way of removing a tooth for our patients. The patients don't feel the pressure of a normal extraction because you're not squeezing the instrument at all. So they're really amazed at how atraumatic the procedure is for our patients. So here I'm placing the beak subgingival onto the root structure. I didn't have a very deep vestibule here, but placing the bumper into the vestibule and simply rotating my wrist, and you can see this tooth moved up and out of the socket, taking a tooth delivery instrument and simply removing the tooth atraumatically to the patient. Now, we had a little infection here, so it's important that you curette the site, curette. And I believe Kurt with Golden has a nice surgical kit if you're interested. I'm not sure how he's packaging it, but we've put together an inexpensive extraction implant kit that we try to keep the cost down. You want sharp instruments, you want high quality instruments. So here I'm just removing any granulation, any purple blood, trying to clean out the site as much as possible. This is what the osteogen plug looks like. It looks like almost like a piece of chalk. It's firm. This is not collagen. You cannot do this type of work with collagen. Collagen is resorbed from the body in about 3 or 4 days. It just becomes snot, and it will not predictably build bone for you. So it's this again is a calcium and phosphorus materials in a Achilles tendon matrix. And what I'll simply do is take it to the site, and I'm placing it into the socket, and it'll actually form to the shape of the socket. You're condensing it, but not like amalgam. You're firmly placing it into the socket site. And I'm not putting a membrane here. I'm going to show you membrane techniques in a moment, but I'm simply going to put a couple cross-stitch sutures to hold the material in place. Now, I think it's very important that you tell your patients that this is a white material. It's not pus, it's not infection, and it's supposed to stay there. I'll see my patient in a week to remove the suture, and that epithelium will grow right over the surface of that membrane. Epithelium grows about 0.5 millimeter a day, and it doesn't take long to cover that over. This is what it looks like immediately at placement, and you can see, we can still see the shadow of the socket, but over a period of about 3 months, you can see how this socket changed. It's more opaque. It looks more like the surrounding bone. After 3 months here, we're going to go ahead and place our dental implant. We have good attached gingiva. We have a site that is acceptable for a dental implant. We're going to place our implant. The type of implant here is really irrelevant, but we're going to use the Hahn dental implant. We have a series of burrs. Again, this is not an implant training course. We'll take a pilot drill, and then we'll widen the osteotomy. And here we're harvesting the bone, and we do histologic evaluations on this bone. I will actually core, and son of a gun if it isn't human bone over a period of time. So a remarkable result. Here we're taking our osteotomy burr. This is a Hahn implant from Glidewell Lab that we're threading into the socket site. We get a great initial stability, 45 Newton centimeters of torque, which allows me to immediately place a healing abutment. A healing abutment is a tall screw that penetrates through the soft tissue. This is immediately at surgery. You can see it's a very atraumatic procedure for the patient. immediately post-operative radiograph, and we can then allow this to integrate and place it abutment and crown in the future. We can implement this type of product into our practices, every one of you here, and this is something that you can get through Golden Dental Solutions if you so choose. The basic grafting techniques when you have all four walls intact. What if you don't? What if you don't have that? Or what if in this situation, let's look at a situation number 2 where we have all four walls intact, but we're going to use a different protocol. We have a tooth, maxillary molar tooth, that is root canal treated, deemed non-restorable by our endodontist, referred to us for extraction. So we're going to atraumatically remove this tooth using the Golden Physics forcep, maintaining the socket site. Now this is important. I'm going to slow down. I know I'm talking quickly. I'm going to slow down for just a moment. We have different materials that we can use to graft a site. We can use allograft, which is human bone. It comes in different shapes and sizes. We can have cortical bone, which is the outside of the bone, hard pieces. We can have cancellous bone, which is medullary bone. We can have mineralized or demineralized, and that's just how the bone is processed. Cortical bone takes the longest to resorb. Cancellous bone resorbs quicker. Mineralized bone takes longer to resorb. Demineralized bone resorbs quicker. But the most important thing, regardless of which material you're using, is that we protect the socket site from invagination of epithelium. Epithelium grows about 10 times faster than bone. And for those of you who have taken courses and tried grafting procedures in the past and have not had good results, this is a very important part of the program where I'm going to show you a technique that if you follow it routinely, you will have very predictable results. We have a socket. We're curetting it out, getting all the granulation and purple blood out. And what I need you to do is to elevate the soft tissue away from the socket. And I hope you will feel comfortable with it. If you don't, Kurt with Golden Dental can explain some of the courses that we do at our University of Detroit Mercy Dental School. But in this situation, we simply want to take a periosteal elevator and kind of peel the facial tissue and the palatal tissue away from the bone. I want to be able to put a membrane at least 2 millimeters apical to the defect of bone. So if there's no defect, I need to tuck my membrane at least 2 millimeters past the defect on the facial and palatal. That will allow the membrane to maintain loosely without any pulling or tearing, and it will allow protection of the grafted material from invagination of the soft tissue. If we have all four walls intact, we want to create an envelope flap, meaning we're removing the tissue from the facial lingual. I'm not making any vertical incisions, just enough to be able to tuck my membrane passively into that site. When we can get primary closure or within 2 millimeters, we can use what we call a resorbable membrane, something that the body will resorb. The literature will say if our closure is more than 2 millimeters, meaning we can't get complete closure, then it's recommended that we use a non-resorbable membrane. However, there are many membranes available that last a good 8 to 12 weeks, so they act like permanent or non-resorbable membranes. And Kurt with Golden Dental can describe some of those products to you when we finish. So in this situation, we're going to use a demineralized bone in a putty form. We're going to inject it into the site. This is probably the easiest way to actually graft a site. It's a little more expensive to do it this way. And I just want to remind you too, if you do have questions, please call them or type them in, and we'll address them at the end of the program. So here I've placed my membrane onto the facial bone, and you can see I'm not holding it in place. It's very passive. Unfortunately, many of us, when we try to put membranes, and we kind of understand that process, we have a tendency to try to force the membrane into the tissue, or we try to lay it on top. And that, if that membrane comes out or loosens, the entire case becomes unpredictable. And one of the first things I said to you in the program is we want to create predictable results. So I put my membrane on the facial, I'm placing my graft material into the socket, I'm then simply going to fold over my membrane and engage the palatal aspect at least 2 millimeters on solid bone. I'm going to suture my membrane with some cross sutures, and you can see the membrane is exposed, and our facial attached gingiva is intact, and we will allow this to heal. I will bring the patient back in a week or so, and I will remove that membrane. And you can see what's underneath it. Now, some of you may say, what is that? It's not epithelium, it is osteoid. And osteoid is the precursor to bone. And in a week, this will be completely covered over with epithelium, and we'll have an outstanding site for a future implant. We were able to keep the sinus from collapsing. I'm able to, in a matter of 4 months, place a dental implant predictably. This is a flapless procedure with a healing abutment. We're able to allow this to integrate, and after a short amount of time, we have great tissue cuff. We make our final impression of our implant. This is a Kettenbach impression material. For those of you who are not familiar with it, you may want to write it down, Kettenbach. Google it. A great product that you buy direct, and it can save you a significant amount of money on a material that you really throw away when you're done with it. So I strongly recommend you at least look into that. I will make custom abutments oftentimes, and you can see my margins are at the gingival line angle. I don't make my margins significantly subgingival, and we can make an ideal Bruxer or zirconia crown that looks better than anything they have in their mouth. Now, these patients, we address a particular concern with the patient. These patients will oftentimes allow me to restore the other teeth in their mouth properly. So just very, very quick, another product from Golden Dental Solutions. Again, if you have questions, I know I'm speaking quickly, but we have a lot of material to cover. Please type them in, and we'll address the questions at the end. Oftentimes, for those of us who may not be as experienced with implant procedures, spacing can be a real challenge. And so they brought over, or they provide what's called an MD guide, MD meaning mesial distal. And you can see there's 5 cylinders with pilot drills, 2 millimeter pilot drills that are 6 millimeter long. And they allow us to properly space implants. In our teaching programs, I'm involved with the Engel Institute. If you're interested, Engel, E-N-G-E-L, institute.com, where we train dentists how to place implants on patients. You'll actually come to my office, and I will allow you to place an implant under a very strict protocol, under direct supervision of one of the mentor dentists on one of my patients. It's a remarkable experience. But it allows us to space. And one of the things I said earlier is I'm a big believer that implants are prosthetically driven, and being able to visualize the case finish before you ever start is really the art of dentistry. Well, these cylinders kind of allow you to visualize what the emergence profile will look like in your final restorations. The 5 cylinders are shaped like different types of teeth in the mouth, male and female. And here we have a situation where we want to place 2 dental implants. And how do we space that? Well, I'm using the MD guide to place a bicuspid sized tooth. We always need to be a certain amount away from the adjacent teeth. Periodontal ligament, we need to be at least 2 millimeters minimally, hopefully more. And we need to, in our spacing, we need to be at least 3 millimeters minimally between implants. So here we're using the MD guide. We then take out the pilot drill and put in our little cylinder, and then use my pilot drill cylinder to make my second. And you can see I have basically ideal position. You can kind of visualize with your experience what these crowns are going to look like in the final restoration. The implants are ideally spaced, and eventually we'll be able to restore them with nice looking implant retained crowns. So I think this is pretty awesome stuff. Let's go back to grafting. Let's look at another situation where we're going to remove a tooth, but the facial wall is gone. We call that a three-wall defect. We can use an allograft, which is human bone, and I showed you the putty earlier, or you can do a particulate. It comes in a bottle, you mix it with sterile water, sterile saline, and it absorbs and it kind of becomes a putty, and then you'll just take your curette or a delivery instrument and place it into the socket. Or we can use our tricalcium phosphate that's available through Golden Dental Solution. Let's use the particulate here, and the osteogen plug that we talked about earlier is only for when all the four walls are intact, okay? So we have a tooth that was deemed non-restorable. We have a little periodontal defect here, and we want to remove this tooth atraumatically. Remember, we'd like to hang on to the facial plate of bone, but the facial plate of bone was actually damaged by the fracture of the root. But we do want to maintain the inner septal bone and the interdental papilla as much as possible. So I'm taking my physics forcep, engaging the lingual aspect of the root, 1 to 3 millimeters subgingival, placing my bumper into the vestibule and simply rotating my wrist. You can see my hand position here. I'm holding it with the base of my thumb and one finger. I am not squeezing this instrument. I'm simply rotating towards the eye. I'm rotating the instrument, never squeezing. This tooth will then pop. It will disengage because of the enzymatic action. I'll take my tooth delivery instrument and we will remove this tooth atraumatically, maintaining everything. But we have a defect here. Remember, I curetted and we have a facial defect. And I'm telling you, if you follow the protocol that we're going to describe, you will be able to predictably grow this facial wall. But you can't ignore it. And you have to follow the protocol that we describe. Here's our particulate, a dry allograft material. We'll wet it with some sterile saline and it becomes a gel. And here is a great membrane. It's called EpiGuide from Curasan that's available through Golden Dental Solution. And you can see I kind of cut it to the shape of the defect. I'm wetting it and I'm taking an Orban knife here and I'm going to make my envelope. I'm not going to make any vertical incisions here. Kind of going around the mesial aspect of the cuspid, the mesial aspect of the central, and I'm elevating that tissue like an envelope so that I can see the defect. I'm going to ask you a question before you have a chance to ask me. How far beyond the defect do you need to place your membrane? The answer is minimally 2 millimeters. So you need to elevate this so that you can see the defect. It needs to go past the defect minimally of 2 millimeters. We also have to elevate the palatal aspect so that we can engage our membrane onto the palatal aspect here. So I'm taking my elevator. I'm going to immediately place an implant, pilot drill, widening. Placing the implant, again, is a whole other course, but we want to engage the palatal aspect of the socket. I'm not placing the implant into the socket site. Number one, we don't have a facial wall. And we're placing it about 3 millimeters palatal to the facial aspect of the adjacent teeth. We're widening the site with our osteotomy burr. And we're able to thread our implant in very, very predictably. Now, so the implant's in, but you can see those threads. So we definitely have a facial defect. So I'm putting a little cover screw. I'm going to put my membrane minimally 2 millimeters past that defect. If I have a 6 millimeter defect, that membrane has to go in at least 8 millimeters, minimally. I have my membrane, and now I'm going to take my particulate that's been wetted, and I'm going to fix that wall. Now, there's no reason to overbulk it. We're never going to get more width than the width of bone to the adjacent teeth. I'm then going to fold over my membrane and suture it into position. You can see I've tried to maintain my interdental papilla. I know I've maintained whatever interseptal bone there is. We have attached gingiva on the facial aspect, and we will grow bone. Here's our implant. You can see the grafting material all around it. The area will heal. We had a little removable appliance that the patient would wear, and eventually we can restore this. Here we have another situation where we have a defect, but I deemed it not proper to immediately place an implant. So we have a tooth that, here's another great product from Golden Dental. It's called the Vibroject. If you don't know this, talk to Kurt at the end. What it does, it's a little vibrating instrument that it will attach to your existing syringes. It'll vibrate, creating a motor response to the brain. The motor response is faster than the pain response to the brain. It's similar to when we wiggle the cheek, but it's about 80% of my patients notice a significant decrease in the discomfort of the initial injection into the site. So here we have a tooth that has a horizontal fracture. You can see the horizontal fracture right at the post. We're going to again use our physics technique and simply remove that tooth atraumatically. Flapping using the Orvan knife, my envelope, my techniques are the same in every situation. You can see we have our defect. We're cutting our membrane to site, taking our particulate material. I will put my membrane in, but it's passive. I don't have to hold it. It's not going to go anywhere. It's not going to come out during suturing. It's not going to come out when you remove sutures in a week. I'm taking my graft material, folding over my membrane so that it engages at least 2 millimeters past the defect on the facial and 2 millimeters of bone on the palatal. My suture technique is rather unique. I'm going from the crest to the facial, then I'll turn my needle around and I'll go from the crest or the socket site to the palatal, and that will allow me to not grab onto the membrane during my suturing technique. Most of us, I think, would go from the facial to the crest, and sometimes we'll grab onto the membrane, or our staff will suck it up or problems. So you can see we have nice suturing, and we'll allow that to heal. The patient wore a little removable appliance. In a week to 10 days, 2 weeks maximum, the site heals. We remove the sutures. The little excess granules will come out. After a short amount of time, usually 3 to 4 months, you can see that the site has healed, and we now have a pretty nice site for a dental implant reconstruction. We can place our implant and make our impression and fabricate a nice custom zirconia abutment and a nice zirconia anterior aesthetic crown, and a pretty happy patient in a very difficult situation. Here we're going to use our tricalcium phosphate. We're going to remove a tooth. We're going to remove the teeth that are non-restorable. Very traumatic to lose your front teeth. So we're trying to maintain that facial plate of bone. You can see I'm not squeezing the instrument. Rather, I'm simply rotating my wrist towards the side of the nose, and that tooth will pop. And I'll take my tooth delivery instrument and simply rotate and remove 2 teeth in a matter of seconds, maintaining interseptal bone, maintaining facial plate of bone, and a very atraumatic extraction for maintaining bone, atraumatic to the patient, in a very emotional situation, and atraumatic to me. Trying to maintain any semblance of interdental papilla, I'm going to go ahead and immediately place 2 dental implants. Again, the protocol is irrelevant. We can teach you that at another program. Our pilot drill is placed. We'll widen the site. We will then place our material, and I will thread my implant immediately into that socket site. It torques well. And again, here we did have a facial defect. I could feel it when I was curetting. So I'm making my envelope, and I will simply immediately place an implant. Same technique. Use a membrane, place it properly, use our allograft material, and I am very, very comfortably able to repair any defects. Fold over, fold over the membrane so that it stays intact, suturing, and we will allow those implants to integrate and eventually restore them. As a temporary here, I didn't want any pressure onto those extraction sites, so we made a little snap it type of appliance. The sutures are removed. You can see the membrane is still there. It looks a little angry after suture removal, but the membrane is still there. And we want to keep that membrane as a protector to the allograft material or to the grafted site. We don't want epithelium to go into the site. You can see after healing, we have some semblance of interdental papilla. We're able to make our impression, nice custom abutments, nice zirconia anterior crowns. We're able to lock them into position and give the patient, a fairly decent result considering the complexity of the circumstances. Here the patient has resorption. So how do we do this? We've all seen this, right? Patients lose a tooth, over a period of time, bone shrinks down and in. So what we'll do is same technique, we're able to make an incision. We can see the defect. I'll take a little round burr and I'll make little bleeding points onto that facial aspect. Here's our allograft material and our membrane. Same technique. I use the same technique routinely. I'm able to graft the site, fold over my membrane predictably, suture. It will allow to heal, and you can see over time we have attached gingiva here. I'm using a digital impression of an implant that we placed, and the laboratory will then fabricate a beautiful crown, an ideal situation. We can grow bone predictably today as long as you follow the protocol. Our custom abutment and a beautiful final crown. Anterior, very typical, right? We have concavities of the bone, and these can be very, very tricky. But again, let's just go through the procedure quickly. Here, I am going to make a vertical incision, but my vertical incision is staying in attached gingiva. Try to stay away from the mucosal tissue. Once you incise into the mucosal tissue, you get a tremendous amount of prostaglandin release. You lose control of the flap, and the patient experiences a lot of discomfort. So here I'm making a nice broad incision. You can see the defect. I'm going to go ahead and place a dental implant because I do have bone. I'm placing my implant ideally, but I'd like to correct the aesthetics. So again, I'm taking a little round burr, getting little bleeding points, placing my membrane, placing my graft material, folding it over, suturing it, and I'm able to actually grow a facial plate of bone very predictably. Now we lost a little bit here, but it's not nearly as pronounced as it was preoperatively. Make our nice abutments. You can see how that we were able to plump out that tissue, that bone very, very nicely. Our custom abutment, our final crown. And I'm going to finish up here right on time. It's 9 o'clock. I wanted to very briefly tell you about our courses. We do courses at our University of Detroit Mercy School of Dentistry on the use of the golden physics forceps. We also do a second program, a 2-day program on grafting, where each doctor will actually use the 3 materials that I described with 2 different types of membranes. So you'll do extractions and grafting and grafting of facial defects very, very predictably. It's hands-on, one-on-one or 2-on-1 here. You have a mentor, and we're able to teach you in a nice environment techniques that we demonstrated here very quickly to make your practice predictable and very, very financially rewarding. We can also, in future programs, teach you dental implant techniques through the Engel Institute. I mentioned that earlier. Kurt can give you more information if you want at that, but every doctor actually places an implant under a very strict protocol under direct supervision of myself or Dr. Engel. So I'm going to let Kurt take over and show you some of the things, and if there's questions, we can answer them.
Thanks, Tim. I appreciate it. Let me just get my slides up here for a second, okay? Okay, sorry about that, guys. I'm just going to get my slides up here, and I'll get started. Alrighty. All right, sorry about that, guys. All right, my name is Kurt Lawler. I'm with Golden Dental Solutions. I'd like to thank everybody for joining this evening, as well as Dr. Kosinski, who always does a very excellent presentation. I always enjoy seeing the new clinical content. Thank you, Dr. Kosinski. I'm going to keep my portion really short this evening, so we have time to get to all of the questions. But I wanted to provide everyone a special promotional offer for making the investment of your time with us this evening. If you have any interest in trying any of our products, we wanted to make the investment of your time worthwhile and provide a good special on our products here at Golden Dental. Remember, when you're looking at any of our products, we have very favorable policies here in terms of 90 or 30-day trial periods or money-back guarantee periods on our products, because we truly believe that the products need to work in your hands, and we want to give you the opportunity to make sure that the products are right fit for you and your practice. As noted here on the slide, the promotional code that can be used this evening for any of our products is going to be GRAFT15. So that's just simply GRAFT and then the numeric 15. The promotional code is going to be valid for 15% off of anything we offer, which is a great promotional offer, and we recommend anybody that's on this evening to take advantage of the promotion. This pricing is actually even better than any of the trade show pricing we typically offer, and as a result of the pricing being a 15% discount, we do these specials for a pretty short period of time. This special is going to be valid for the next 1 day or 24 hours. So at the end of the day tomorrow, the promotional offer will have expired. You can learn more about our products at either goldendentalsolutions.com or physicsforceps.com. It'll take you to the same place, or by giving us a call here in the office at 877-987-2284. In addition to the products, some of the products that Tim mentioned this evening, please consider spending some time on our live patient CE program page on our website. Our next program is actually this weekend, but we do about 10 to 12 courses a year. Our CE programs are completely unique, and they're all live patient courses here in Detroit, where we typically will do 200 plus extractions on usually 75 to 80 patients that we provide here at the University of Detroit. There's no licensing restrictions as long as you're a licensed dentist in the US or Canada. And we encourage you to invest a little bit of time on that section of our website and learn about these programs, where Dr. Kosinski is one of our excellent instructors for these extraction and grafting boot camps. So again, I just want to thank everybody for your time this evening. The promotional code, again, is GRAFT15. I'm going to go ahead and just make a mention for our next webinar. We currently have scheduled for June 14th. That's going to be with Dr. Jack Hahn and Dr. Tim Kosinski again, where we're going to cover completely new cases, maybe spend a little bit more time on the implant aspect, and of course, obviously show the extractions and grafting so we can show the cases from start to finish. If anybody's interested in joining that, I guess while it's fresh in your mind, you'll see shortly on our website, there'll be a registration link. I don't think it's up there currently, but check back in the next couple of days and we'll have that up and available for your registration. I believe it'll also be mentioned in the email that we may send following this webinar. So again, June 14th, if you can join us again, that would be great. One last thing here is I'll just do a plug for Tim. Tim really likes our products, and we appreciate his time, and we wanted to mention that Tim did make a good investment recently, a little less than a year ago, to go over a lot of the content that was discussed in the evening, but at a slower pace and greater detail, on a really great DVD where it goes over extractions and grafting for a little over 2 hours, and really concise and clear step-by-step instructions on extractions and grafting. This is a great DVD, and it's been a top seller in the dental industry, and it's very popular. And I just wanted to mention that DVD is available also on our website. It's with the special, it's about $100, if that. So I'll go ahead and leave this code up, and I'm going to go ahead and start getting through the questions here. There's a lot of questions. We'll do our best to get to all the questions we can. Tim, I'm assuming you're on live here too with us still. So let me go ahead and get to the first question here. It says, with the physics forceps technique, you didn't show any elevation. It seems that you don't have to elevate in advance, which may be great, so I don't have to worry about adjacent crowns or porcelain work. Tim, I don't know if you want to take that one.
Yeah, sure. Can you hear me okay, Kurt?
Yep, it's perfect.
Okay. So in my technique, I don't elevate at all. I don't take a periotome. I don't take a periosteal elevator to break down or cut the periodontal ligament, and I don't elevate. And you're right. That's a great question. In that, if you have crowns or veneers adjacent to a tooth you're going to remove, using the physics forceps eliminates the potential of damaging crowns or veneers next to an extraction site. I go right to the instrument. It is a technique. It is technique sensitive. It's different than conventional techniques that we were taught, and so your muscle memory is a little bit different. That's why I strongly recommend, people come into Detroit, work on 20 patients, take out 20, 30 teeth, and really become an expert using the forcep. I think is a wonderful technique. Detroit's an easy airport to get into too, in and out. We're a Delta hub. But yes, I go right to the instrument. So if I'm going to remove a tooth, my staff brings me one instrument.
All right, I guess there's a couple simple questions. I can just take these. Somebody asked, when's the next grafting course? When's the next extraction course? So just to clarify, there's 2 courses. The extraction boot camp's a 1-day program. That's mainly just focused on extractions. We will allow you to do the osteogen plugs and some simple socket preservation techniques, but the extraction boot camp is focused on extractions. For the grafting boot camp, that's a 2-day program where you're obviously still going to remove the tooth, but we give you a lot more time to try each of the products, and we spend more time at that program grafting the sites and not just focusing on the extraction aspect. So just real quick, I mean, all these dates are on our website too, but our next program for the extraction boot camp, as I mentioned, is April 23rd, June 18th, August 27th, and December 10th. And real quick, for the grafting boot camp, the next one looks like it's May 20th and 21st, August 19th and 20th, and October 14th and 15th. So just, again, that's sort of an administrative question, but all those dates are on our website. More than happy to answer the questions if you give us a call. All right, Tim, the next question, again, this isn't too complicated of a one, but what sutures do you use or do you recommend generally when you're doing your suturing of the membranes?
Oh, that's a great question. There's a lot of different sutures out there. And the most important thing is really the needle. All our needles are cross-cutting, 3/4 round. I like to use a 3/0, which has some substance to it. I use what's referred to as a billet or vicryl. It's a resorbable suture, but it's a suture that lasts a long time. I always remove my sutures in a week to 10 days or so. I rarely would leave them in longer than that. But what's nice about it, as it resorbs, it resorbs to water, and so that's the material I like. Again, I think we've become very comfortable with the suture material that we use, but that's the material I like. It's very kind to the tissue, and you saw the results of the tissue in the few cases that I showed. It's pretty remarkable. We don't get a lot of irritation from our sutures.
Yeah, and Tim, I guess a related question to that is, I can't remember if you covered this in there, but we got this question and we normally get it, but do you suture through the membrane?
No, no, and that's an important part, and I know I went through this kind of quickly. You don't suture through the membrane. The membrane is laying on facially at least 2 millimeters past the defect on the facial and on 2 millimeters on lingual or palatal. So it's laying passively. I will then suture on top of the membrane. I'm not engaging it from the crest, from like the socket site to the facial. Then I'll simply turn my needle around and go from the crest or the socket site to the palatal, and then suture it down that way. So the membrane will adhere to the socket site, and the epithelium that grows very quickly will actually hold it down in position very nicely.
Okay, great. How long do you leave the non-resorbable membrane in place following extraction and then grafting? And then I guess a related question to that would be, you know, can a long-lasting membrane potentially be utilized in place of a non-resorbable?
Great.
So I guess those are the two interrelated questions.
Great questions. People were listening. I appreciate that. So the literature will say if you can't get closure within 2 millimeters, we should use a non-resorbable membrane, meaning it has to be removed. And I will remove it after about 6 weeks. Okay, I don't leave it in longer than 6 weeks. And you saw the one case where we have osteoid that's formed, and then the epithelium will grow over that, and we're able to place an implant in nicely. But there are resorbable membranes that last a long time. Like the EpiGuide we showed you, it has a very special composition, and it will last about 12 weeks. Well, if I'm removing the membrane in 6 weeks, I could just use that. So if you wanted one membrane, that's the one I would use. As you're talking to your reps and your suppliers, it's very, very important that you understand what you're buying. And the question you should ask the reps or Kurt, if you're going to go through Golden Dental, is how long does that membrane last? Because if it lasts 6 weeks or more, you pretty much can use it universally. Great question.
Okay, somebody had a question about, you know, I know we try to keep the grafting pretty simple in our programs and provide just 2 or 3 good options so you know, people don't get confused with the many products out there. But this question is related to that, where they ask whether the beta tricalcium phosphate or maybe the allograft materials, can they pretty much be used interchangeably, or is one slightly better than the other in preserving volume, or does the body really respond, you know, the same to each type of product, I guess?
Awesome question. So in my practice, again, there's a lot of materials out there, as I said, and let's cut to the chase. I'm showing you things that work in my hands, and I have 3 different products in my office. I have tricalcium phosphate from Curasan. I like that because it's a synthetic material, and many of our patients who may be adverse to placing human bone have no adverse reaction to something that's synthetic. It's basically a salt made in a laboratory, and it's very, very predictable for sockets where all 4 walls are intact. Okay, Osteogen is another great product when all 4 walls are intact. When you have that cereal bowl, Kurt, or the waffle cone, or the ice cream cone, where you're placing something in it. If the facial wall is gone, if you're missing the facial wall, then the literature will say we should be using an allograft material, and that's more predictable. But the most important with all of those products is that we protect it from invagination of epithelium with the membrane.
Okay, perfect. I can probably take this next one real quick. It says if I've never tried the physics forceps, which set should I try first? The standard series? Is there any training with it? The answer to that is that we have 2 sets, and I think Tim showed both. The standard series set is our most popular. That generally will cover the full mouth with the exception of erupted thirds. And sometimes you may not get back to the second molar, which some users on the line this evening would probably agree. The standard series really gives you the best leverage, and that's the set to start out with to see if you like the concept and the technique. They're probably a little bit easier to use than the molar series. The molar series has a specific purpose of going further back into the mouth. They have a thinner bumper, and the bumper can be placed on the buccal or the lingual side of the tooth, which is unique to the molar series. But the standard series is generally the set that people take a look at first to see if they like the concept of the technique. And I say, make sure they like it, because like I said, the product's got 90 days to try it in your own hands, 3 full months to see if it's a good fit for you. And that's generally what we would recommend. And does it come with training? Absolutely. It comes with a great training DVD. We try to update it every year or so with new cases. Goes through the techniques and the tips on how to use it. But the biggest hurdles to get over is you got to just remember it's not a forcep. It's really an elevator, so no squeezing, and you have to be a little bit patient with the product. So if you can get over those hurdles, most people have pretty immediate success with it. Otherwise, once the technique is down from watching the training DVD or any of the videos online that Tim produces on a regular basis, those would be some suggestions on how to make sure you're comfortable with the product. All right, the next one is, it says, I place a lot of dental implants. I'm concerned about the bone. Will this instrument really work well for us that place implants, including immediate implants? When I say work, will it not break the bone?
Let me grab that one, let me grab that one, because I think that's a very legitimate concern. And as I mentioned, I think that for those of us who have learned a certain extraction method, we do squeeze and we do break facial plate of bone. And I think there is a learning curve. I think there is a learning curve with the instrument. And the most important thing that we have to demonstrate is that we don't squeeze the instrument. We just create tension on the lingual or palatal aspect of a root, and the tooth will come up and out of the socket. If we use it correctly and we don't rush it or force it, and it may take several minutes to get a tooth out, then we minimize the chance of fracturing the facial plate of bone. Is that to say that we never do? Well, that's silly, because in the anterior maxilla, the facial plate of bone can be paper thin. But what we wanted to demonstrate today is that if the facial plate of bone is damaged or removed, we now have a predictable way of growing bone on that facial defect, into that facial defect. And I think that in our level 2 course, Kurt, I think being able to demonstrate this technique with 3 different materials and 2 different membranes is an invaluable experience for our doctors.
Sure. Okay, great. I guess I'll get to one question here on the WAM key. There's a few comments out there about zirconia is very difficult to remove. Will the WAM key work with zirconia crowns? Because it mentions that the zirconia is very difficult to remove and can use expensive burrs.
Absolutely, and zirconia is cut using a fine diamond particles. And what I'll use when I have a zirconia crown is I just have to make that small window. I'll use a little diamond cutting round burr to make that little window through the zirconia. So I'm not spending $40, $50 on burrs trying to cut through or slice through a zirconia crown like we would traditionally. I think it's a great instrument for that. That alone is phenomenal.
So Tim, that'd be like a zirconia ball burr.
Yeah.
Is what
right. Well, there's diamond. There's actually small diamond chips on that. The diamonds are what cutting the zirconia.
Okay. Let's see here. It's kind of I guess I'll ask, this is kind of a hard question maybe to answer, but I guess it says, what's Tim's secret to getting patients to pay for implants? I have implant training. but insurance doesn't cover implants, as you know. What's the secret to place so many implants?
My wonderful personality and smile, Kurt. I've been doing this a long time, and I'm a big believer. Okay, and this is a marketing thing. Um, I think that if you want to become proficient at implants, number one, you have to understand your overhead and what a fair cost is to get these procedures done. And I think everybody is on a budget. And look, we're in Detroit, the hardest hit economy in the country, arguably. And everybody's on a budget. And I think that it's just important that you try to work within that patient's budget and make it important to them. My team is wonderful in doing that. I can explain the procedures. The internet's changed everything. The patients are very understanding of what implants can do. It's just a matter of working within their budget. And I think that's the key.
Okay, great. I think we touched on that a little bit more too at our program. Not in great detail, but I think Aaron Azarian's got some great tips too for case presentation and things that we go through. So that is part of a little bit of our program for the level 2 program. All right, maybe I'll get to time minutes here. I'll just do one more question probably. It says, is the VibraJack effective for palatal injections in your experience? What percentage of the patients seem to respond positively? I've been shaking the cheek for a number of years, but this seems probably like a better approach as my patients sometimes wonder what I'm doing.
Yeah. You know what? I think the VibraJet is a really wise investment, and I'll put it enough. Yes, it does work on the palatal. And I'm going to say about 80% of my patients notice a significant decrease. They're kind of surprised. But the best thing that I can tell you is we have it in every room, and my staff has it ready for me on every patient. My staff believes in it. It's not something I have to ask for or to find or let's use this. It is just there because they believe in it, and I think it is a very wise, inexpensive tool to help your patients have a positive experience.
Okay, perfect. I guess just to keep on time here, I think we said we were going to finish about 9:20. So anybody can always obviously submit questions to us or give us a call. More than happy to loop you up with Dr. Kosinski on anything that we may not be able to help you with. Tim, thanks a lot, and thanks for everybody that invested their time with us this evening. Again, we're available here anytime in the office for questions, and we appreciate everybody's time this evening. Tim, I don't know if you have anything else to say or.
Nope. Thank you, Kurt. Thank you, everybody. Enjoyed it.
Have a good night, everybody. Thank you.